So these are the updated Scottish Intercollegiate Network and NICE Guidelines 2024. So I don't know how many of have you read the new guidelines which came in end November 2024?
No.
Because they are for adults and for children as well. So it's actually comprehensive guideline. It covers the adult asthma as well. Okay, if you do get a chance, do download the guidelines and give it a read. Okay. Anyhow, the pediatric component of that, especially the hospital one. So I'm just like I've consolidated that all those guidelines in one slide. Okay, and just follow this. Okay, so these are the totally updated guidelines. Okay, some of them are repetition from 2019 guideline, but there are a few things that they have updated. Okay, so you just remember this thing. So in cases somebody challenges you that, oh well, we are not used to this practice or that practice, then you can tell them that it comes from the latest guidelines, and the one who is challenging you should go back and read and update their knowledge. Okay, so this is about the hospital management of acute wheezing episode, irrespective whether they are coming with whether you think the underlying cause is asthma or whether the underlying cause is viral wheeze or whatever. Most of the time the management remains the same. So it is categorized into four categories. Again, these four categories are from the previous guidelines: mild, moderate, severe, and life threatening, and they've got a criteria for that. Again, I have only picked that criteria which is relevant to our practice, because there are certain parameters which we don't check normally, like peak expiratory flow rate. I mean, we don't have peak flow meters and we don't use it because it requires sort of a compliance from the child. Most of these kids are very young; they cannot be compliant with these things. So mild, moderate, severe, and life threatening. So there are a few clinical parameters which actually uh, classify these kids into these categories. The first one is oxygen saturation. And most of these things, they would be done at triage level. So once the nurse has done the triage, you look at the triage sheet and you would be able to categorize the child, whether he falls in mild, moderate, severe, or life threatening. So mild and moderate, remember the two of them, mild and moderate, the two M's, they always have got normal saturations on room air. The other two, severe and life threatening, they always have got low saturations. So one should be clear: if the saturation rate is normal or above normal, like 92 is the threshold level, then that child has either got mild or moderate. If the saturations are low, then you have got the child who has landed in the severe or the life threatening category. Life threatening is quite rare. I mean, luckily that's quite rare. The other thing is respiratory rate. So the respiratory rate, again, I tell you one thing: we use the WHO criteria, World Health Organization criteria, and that is the cutoff levels for respiratory rate, or where you would classify somebody as having tachypnea, is up to 2 months. Respiratory rate of 60 up to 60 is normal. Between 2 months and 12 months, up to 50 is normal. Between 12 months and 5 years, that is like 1 year and 5 year, 40. So remember, 60, 50, 40. 60, 50, 40. 60, 2 months, 50, 12 months, and 40, 60 months or 5 years. That is the respiratory. So in mild, the respiratory rate is always normal. It would be less than those cutoff values. The SATs are also normal, and there is no or very minimal work of breathing. In moderate, SATs are fine, but there is tachypnea, and there might be slight work of breathing. So there would be tachypnea, there would be work of breathing, but the SATs are fine. In severe, SATs are low, tachypnea is present, and work of breathing is present. So the one differentiating point between moderate and severe is just the SATs. They are presented the same way. So a child who has got recessions, working hard, tachypnic, you look at the SATs. That's why, when the nurses come, oh, doctor, can you see this child? Look, I said, okay, well, fine. What are the vitals like? Oh, he's tachypnic, his respiratory rate is high, is elevated, he's working hard. Then, okay, what are the SATs? The SATs are normal. Okay, fine. He lands into moderate category. The SATs are low, then he goes into severe category. What happens in life threatening? You've got low O2 SATs, You have got tachypnea, but the respiratory rate is very poor. These kids have got silent chest. They're almost exhausted. You won't find much work of breathing in these kids. They are almost like in a peri-arrest condition, very bad, like they might be gray or cyanosed. Luckily, that's very rare. Okay, I doubt you would come across these, because if these are the kids who present, that would be a straight away pediatric cardiac arrest call, and so probably they would be in that condition where they would require an HDU or ICU or intubated or non-invasive ventilation. I mean, then that is altogether a different, ball game. Or most of the times, 99% of the times, we would be dealing with mild, moderate, and severe. So mild and moderate, SATs are fine. In severe, the SATs are low. In mild, your tachypnea, your respiratory rate is normal. In moderate and severe, your respiratory rate is high. Work of breathing is present in both moderate and severe, but in mild is like minimal or not at all. Whereas these kids are alert most of the time, except the life-threatening work, where they are usually very much toxic looking and also cyanosed. If you auscultate the chest, in mild ones, you might hear a faint wheeze or you might not hear a wheeze. In moderate and severe, wheeze is always present. While in life-threatening, usually the chest is silent because they're very poor expiratory effort. The chest is moving very slow. Now, coming down to the treatment, how do we treat these kids? Okay, where I think the practice needs to change. So, a child who has got mild, let's say you've categorized, and that child has got mild. Why? Because the SATs are fine. There is no tachypnea. Minimal work of breathing. Otherwise, everything is fine. Maybe there is a prior history, or there might be a little bit of wheeze or no wheeze at all. So you give them 10 puffs of salbutamol and then reassess. So we are not giving nebs. We are giving what? Inhaled salbutamol.
Salam in children's ED. That's full salam in children's ED.
So you will ask the nurse to give him 10 puffs of salbutamol, then leave the child for 15-20 minutes and reassess. Then reassess. So if the child has improved, let's say there was a little bit of wheeze and that is gone, fine. Okay. But let's say there was no wheeze and then you've given them 10 puffs or 4 and then the wheeze appeared, then what you will do, you will repeat this every 20 minutes for a total of 30 puffs. That is like 10 puffs every 20 minutes for 1 hour. If you repeat every 20, you will be giving 30 puffs over a period of 1 hour. And this is the same that has been carried from 2019 BTS Sign Nice Guidelines. But you are not adding any steroids. You do not give steroids in mild one. You just treat it with salbutamol. So a total of 30 puffs, reassess. If they are improved with that, okay, if they are improved, then they can be sent home, okay? You wait for another half an hour so the symptoms they don't, and you send them home. At least 4 to 6 puffs QDS for 5 days and follow up with the GP. For moderate, you also do the same thing. Moderate is also the same thing. You will be giving them 10 puffs, reassess, and then you repeat, every 20 minutes for a total of 1 hour, that is 3 times, and you will reassess. If they have improved, you will do the same thing that you did in mild category. But if not, then you will switch over to what? You will switch over to nebs. So first 1 hour would be 10 puffs every 20 minutes. If there is no improvement, you move on to in the second hour, you will move to nebs, and with nebs, you will give steroids. So you move on to the right side, like you move the child from the moderate to the severe category. So if they have not improved, you go to the severe one, and then what you will do, you will give them salbutamol and ipratropium nebs every 20 minutes for 2 hours. So that means if a child is less than 5 years of age, you give them salbutamol 2.5 and ipratropium 250. Usually less than 1, we use 125, but between 1 and 5, we use 250 microgram of ipratropium and 2.5 milligram of salbutamol. And you have to repeat again every 20 minutes. And at the same time, with the first one, remember with the first one here, a mistake which normally most of the doctors they do is they start them on nebs, and if nebs are not, then they add steroids. The guidelines say start steroids early, post like preferably with the first neb. So when they have got the first neb, ask the nurse to prepare some prednisolone and give them 1 milligram per kg. And the new thing which has come in the 2024 guidelines is that you now can add 150 milligram of magnesium sulfate for the for 3 nabs in the first hour. So you can give a total of 3 magnesium sulfate nabs to the severe, those who have got low sats. You can start them along with, so you're starting with salbutamol, ipratropium, and magnesium. So instead of giving 2 medications in one nab, you are actually adding 3 medications. So you are adding salbutamol. Let's say the child is 4 years of age, so 2.5 of salbutamol, 250 of ipratropium, and 150 of magnesium sulfate. So first hour, 3 nabs should have 3 medications. So remember 133 for severe one. So first hour, 3 medications. That means salbutamol, ipratropium, magnesium sulfate, and 3 times. So in first hour, the 3 nabs would just include salbutamol, ipratropium, and magnesium sulfate. If they're not improving, if you go to the next hour, again, next hour would have 3 nabs, but that would only contain 2 medications, that is salbutamol and ipratropium. And if it's still those are not working, then you will move on to the second line medication, which is magnesium sulfate, 40 milligram per kg to a maximum of 2 grams over 20 minutes. So the new here is that magnesium sulfate, in the previous guidelines, it said first 2 hours you just give them salbutamol and ipratropium and you steroid, and if they are not working, then you would give them 1 nap of, that was the transition, 1 nap, 150 milligram of magnesium sulfate while you were preparing the IV magnesium, and after that you would switch over to IV. Now they say no, first 3 naps should contain magnesium sulfate 150 micrograms. Then you will move on to 2 medications for another 1 hour, and only then, if they do not work, you will move on to IV magnesium sulfate. It's very clear, okay? Just tell him, somebody challenges you, tell them, go back, open the net, okay, download the guidance and read. You can give a total of 6 nabs of ipratropium in 2 hours. 6. They are challenging you on 2, 6. So please, if you are treating a child who has got severe, you can go up to 6 nabs, okay, which can be ipratropium. Okay, they say, oh well, we don't give ipratropium. Well, say you don't. It's evidence based. Okay, it's evidence based. Ask them to go and open the guidelines, or sometimes I just hold them by hand and open the computer and say, look at this, what's written there. Is it clear to you guys that the new thing here for severe, like who's severe? Somebody whose sats are low. So when you start them on salbutamol and ipratropium, you can add magnesium sulfate, or the guidelines recommend adding magnesium sulfate nebs 150 microgram in the first hour. So all those 3 nabs that will go every 20 minutes, that should have 150 milligram of magnesium sulfate. Then if they still do not like sort of respond to that, the next hour should be just salbutamol and ipratropium. And after 2 hours, if they still don't respond, obviously with the first one, prednisolone is also there, like 1 milligram. And then you can switch over to IV magnesium sulfate at a dose of 40 milligram per kg to a maximum of 2 gram, which has to be given over 20 minutes with the child attached to cardiac monitor. And magnesium sulfate is a very safe medication. I mean, unlike what the literature says, hypotension, things like that very rarely occurs in kids. Haven't yet to see anybody who had like hypotensions or collapse with magnesium sulfate. Another one thing, if somebody vomits prednisolone, somebody vomits prednisolone, and let's say there's within 5 minutes, if somebody you give and they vomit, you can repeat the dose. But again, it's your choice. I mean, the new research, again, this is not the part of the NICE guidelines, but from Nelson textbook of pediatrics, oral dexamethasone or intramuscular dexamethasone can be substituted for prednisolone as well. It's your choice. You can give intramuscular or oral dexamethasone, because the taste is a problem with the prednisolone tablets that we have, like, in our formulary. The prednisolone tablets, they are basically not pediatric prednisolone comes in a liquid preparation, but it's because it's expensive. I think the hospital pharmacy is not buying it, so they just give us the cheaper tablets, which they have to dissolve, and it tastes like bitter almond, like, oh god, it's got a horrible taste. So most of the kids, they do not like the taste, and they usually gag or vomit after that. So depends, if the child has vomited, either you can repeat it, or you can just switch over to dexamethasone. Again, oral and intramuscular, your choice, whatever you think. If the child is very much fussy, is not like orally, then obviously you can give intramuscular. Okay, but here important thing is magnesium sulfate, and magnesium sulfate really helps. Okay, when you give 3 naps, probably you won't even you will reach the need for intravenous magnesium sulfate, because it helps us in opening up the airways. So either you can take a screenshot of this slide, or just remember it. Okay, just remember it. So if I have to summarize the 2024 guidelines, mild, moderate, severe, and life-threatening. Mild and moderate have got normal SATs. Severe and life-threatening have got low SATs. Okay. Tachypnea, there is no tachypnea in mild, but there is tachypnea in all the other three. Remember, the mild and moderate are treated with inhaled salbutamol, not with nebs. So do not rush to the nebs. Inhaled has got less side effects, less tachycardia with it, and it's equally effective as nebs. Again, time and again, research has shown that inhaled corticosteroids are as good as even IV corticosteroids. IV corticosteroid I didn't discuss here, because sometimes if a child has got life-threatening, usually, I mean, because they are so like sort of obtunded, usually you have to pass IV line, and in that case we give IV hydrocortisone, so 4 milligram per kg IV hydrocortisone. But by that time you would have placed a call, okay, and the team would be there and they would do all those things. On your own, you would be dealing with most of the mild, moderate, and severe asthma cases. So you should know, if you have to start nebs, now you've got the evidence to add magnesium sulfate to the first 3 nebs, and the rest you need to treat them with the inhalers in the mild and the moderate category. Only in moderate, if they're not responding to inhale, then you will switch over to nebs along with the oral prednisolone. So these were the the crux of the 2024 updated asthma guidelines. There is much which has changed on the chronic side, or chronic management of chronic asthma. So instead of now of giving them mild to moderate doses of what you call inhaled corticosteroid, now they have moved towards a combination of inhaled corticosteroid with long-acting bronchodilators. So anyhow, I mean, in the last probably 1 month, I have switched some case from ICS inhaled corticosteroids to combination of LABA and ICS. But anyhow, I don't expect you guys to be remembering that's altogether a different ball game. Anyhow, for management of asthma, just remember these things. And a few other important things is, if let's say if somebody is not improving, there are a few things that you need to do. Remember, all those who have not improved in the first 2 hours with nebs, okay, whether there was a magnesium nebs, so 3 ones or 2 ones, they should have a chest x-ray. Chest x-ray is mandatory for those kids. Also, a child who is not improving, along with the chest x-ray, should also have got a cap gas and VBG. It's important that they are not retaining carbon dioxide, so they're not in type 2 respiratory failure. And whenever a child who has improved, and most of the time you will be dealing with this category who have improved and they are being discharged. They must have their inhaler technique checked. Please, please, please. If you are doing it yourself, do it yourself. Otherwise, ask the nurse to check the inhaler technique. Believe me, trust me on this one. I have seen many times when they say inhalers are not working, it's simply because their technique is not proper. Most of the parents, they are not like, they are that sort of parents, okay, where the child is moving around, they just give up. Okay, so the child is actually inhaling air and the medicine is being discharged into the air. Check their inhaler technique. So if they're not improving, chest x-ray and VBG or cap gas, whatever. And if they are improving and being discharged, check their inhaler technique. So that was all about management of asthma and a wheezing child based on the updated 2024 guidelines. So what I need you to remember from all this, obviously everybody tends to forget because we have so much to remember. Just remember the new things that have come up. Okay, that is, while mild and moderate, you just need to go with the inhaled salbutamol. And if they are not improving, especially the moderate one, you treat it as severe one, and then you will start NEBs. And in the severe one, in NEBs, first 3 NEBs, you can add now magnesium sulfate 150 micrograms. Instead of giving 2 medication, now you can give 3 medications along with oral steroid, which should be given with the first NEB. Any questions now?